And I've been asked today to talk to you a little bit about how to get through the arthroplasty part of your exam, and I've really focused on hip today. So the first piece of advice is, this is your examiner. He is a sleeping bear. What you don't want to do is say anything in this exam or part of the exam that means that you're poking the bear, because you don't want to wake him up. That's my big piece of advice, and hopefully the tips I'm going to give you here will avoid ever poking the bear. Okay, so this is pretty much a guarantee that you're going to get asked a question about hip osteoarthritis. Patients come in with hip pain or groin pain, they're complaining of stiffness, it's waking them from sleep, they have a limp. This is very, very common. Okay, and we have to do a history where we get all of that information, and then we do an examination. And the examination really is what is look, feel, move. So you look at them walk, they walk with a painful antalgic gait or a stiff leg gait. And they may have a slight Trendelenburg gait. But then you're going to look at their hip movements. So as you flex them up to 90 degrees, you want to note if they're going to go into obligate external rotation, because they've got a very stiff hip. Other tests that come up in MCQs more than anything are these ones. So the Stinchfield test is resisted hip flexion, which is where you ask the patient to straight leg raise and you press and they get pain anteriorly. That suggests they've got an anterior loss of cartilage. Likewise, the Patrick test, which is a figure of 4 type test, again, that can give you anterior pain. It's less specific, and it's not a great test because you can also get pain at the sacroiliac joints, and then you need to do your Faber's and Feder's test to see if there's any other SI joints or hip pathology. But these are common tests that come up in MCQs, and if you don't know the names of them, they don't explain them for you. Then you also want to know if they've got fixed flexion deformity. So this is Thomas's test. My advice in the exam, if you have to do a Thomas's test, get the patient to bring their knees so that their legs can go flat off the edge of the table, so that their legs are dangling. Bring both their knees up to their chest, and then as you extend one of them, if they can get it all the way flat, they don't have a fixed flexion deformity. But like in this test, in this picture on the bottom, you can see that they've got a 5 to 10 degree fixed flexion deformity because it's not coming all the way down to the couch. So these are the common tests. But the mainstay of what you're going to probably be shown is an X-ray. So this is the commonest, and realistically in primary arthroplasty, the only and best investigation that you need, which is an AP pelvic X-ray. You can also have a lateral of the affected side. And the features that you're looking for are loss of joint space, because what that is, in essence, we can't see cartilage on a plain radiograph. So as that cartilage is worn away, you lose the joint space. You then may see cysts. So cysts are formed when the fluid that's within the joint is pushed through that broken cartilage and it goes into the bone and it causes a cyst. Bone tries to repair itself, and the way it does that is by getting tougher, by laying down more bone, and that's what happens with this sclerotic bone. So the bone's reacting to try and make the environment tougher. And if you compare that to the other side, you can see that there is a normal hip with a good joint space, and none of the other features. The X-ray I've shown there is a very arthritic hip, so they would need an arthroplasty. Other imaging that is important to know about, CT scan. So these are really for planning a complex primary hip. So if they've got a deformity or you're worried about any specific bone loss, then a CT scan is good, but it's not commonly needed for a primary joint arthroplasty. However, in the revision setting, you should definitely get a CT because you're trying to reconstruct, so you need to know if there is any defects, if they're contained, if they're not contained on both the femoral and the acetabular side. MRI scan is realistically only used for if you think you've got osteonecrosis in the primary joint setting, but in the revision setting, I use it. Well, if you've got a metal on metal hip, you'd want to make sure you've got one, but also you may get it to look at the quality of their muscles, because it may help you choose the bearing surface in your reconstruction. So I would go for a dual mobility type bearing if they've got poor function of their hips. So on the MRI scan, you would see atrophy and wasting of muscles. So moving swiftly on to management, by the time you see your patient, they should have gone through most of these. So non-operative management includes reduction of weight, modification of their activities, physiotherapy, painkillers and anti-inflammatories, a walking stick that they should use in the opposite hand because of the biomechanical advantage that gives you to decrease your joint reaction force. And then joint injections. So what I would say about a joint injection for me is it should only be used as a diagnostic test. So if you think somebody has arthritis because of their symptoms, but their x-rays don't match up, or they've also got concurrent back pain, then if you do a joint injection where you put dye in the hip and then you put just local anesthetic in, it will only last for around 4 hours. But if that gets you a very good result and takes away their pain, that tells you that a joint replacement is good. It will be a good option for that patient. If it takes none of their pain away, then it's not going to be a good option. It will be more likely that you should investigate their back and look into doing an MRI scan of their back and looking for nerve entrapment there. The reason I say diagnostic with local anesthetic only is because if you put in a steroid, you can't or you shouldn't do a primary joint arthroplasty for at least 6 to 9 months, because the literature has shown that it increases the infection rate from around 2% to 5 to 7%. So if you've got somebody who is not fit for surgery, then by all means give them a steroid injection, try and get on top of their pain. But in my experience, it only realistically lasts a month at best. And therefore, if you give them a injection with local and steroid, they're likely to have 7 to 8 months of pain before you can safely go in and give them a primary joint replacement. So moving on to what we do. So total hip replacement, it's successful operation. It's in the UK, it's done in about 60% of women versus 40% of men, and the mean age of which we're doing arthroplasty at the moment seems to be around 68. It's slightly younger if you're doing an uncemented hip, and slightly older if you're doing a fully cemented hip. And this graph here is taken from the most up-to-date NJR figures in the UK, and you can see that uncemented hips are the most common. And for the first time, the hybrid hip replacement, which is a cemented stem with an uncemented cup, has overtaken a fully cemented hip. And I'll explain some of the reasons why as we go on. So in the exam, to not poke the bear, the examiner, my advice would be to say that you would do a posterior approach. Even if you don't do that in your practice and you're very comfortable talking about a direct lateral or an anterolateral approach, that they're not incorrect answers, but for me, in the exam setting, you want to say posterior, because one, you do it for both primaries and revisions, and it's the only extensile approach to the hip. So if you need to learn any approach to the hip, learn this, because you can extend it proximally into a Cocker-Langenbeck. So if there was an acetabular problem, you can view the whole acetabulum and you can reconstruct. So if you had a surprise on table in your primary arthroplasty, you will be able to dissect enough to be able to see all of the anatomy. Likewise, if you were to have a problem on the femoral side, you can extend this all the way down to the knee. So therefore, for me, the best approach, and it's the approach I use, but in the exam, this is the answer you should give. It will not wake up a sleeping bear. They should be happy that you say posterior approach. Okay, enough said on that. So if we look at cemented stems, so cemented stems are where John Charnley really came in and contributed. He gave us low friction torque arthroplasty. He used a 22.225 mil monoblock head, which he cemented in, and he brought us bone cement and polyethylene cups. And this was the mainstay of joint replacement. And if you look at the survivorship, it lasts a very long time, 25 years, 81% survivorship. So I think that's a really good success. But designs of cemented stems have changed. So there are two types of cemented stem that you need to know about. One is a composite beam. So the composite is that of your bone, then your cement, and then the metal of the stem. These are designed differently, so they're much bigger, and what you have is a stem with a very rough surface. So what you're trying to do is get your cement to go into all of those nooks and crannies to bond to the stem within the cement. You would not expect these to subside, so they would be placed, and then you wouldn't expect them to move at all. However, more modern designs include the taper slip type design, which is where you have a taper where it goes from a wider approximately to thinner at the base, or from front to back, or from side to side. And this is like the Exeter type stem. They're usually highly polished, and the reason they do that is because you want them to slip and go further into the cement over time, so they wedge in. So they're designed to subside, and typically a millimetre in the first year. And what this does is, as it's pushed in as you walk, it then gives lateral hoop stresses. So it loads the bone in a different way to a composite beam. And this is what the modern cemented stem designs are based around. Cementing technique is something also to be thinking about. So the first generation technique, which is what John Charnley did, they mixed everything in a bowl. They would leave their cancellous bone, they would vent the femoral canal, and then they would hand pack the cement into the canal, and then they would place their stem into that cement mantle. As things have progressed, what we do now that's mainly different is we mix in a vacuum. And what this does is reduce the porosity of the cement so that it makes it stronger and less likely to crack and break and fail. And as you can see from this slide, you can see all the other things that we do. So we have cement restrictors, we pressurize, we wash the canal, we dry the canal, and we do everything very specifically. And this is getting, better cement mantles for our stems. So how good is your cement? So Barrick grading is what we're looking at here. And what you want is a Barrick grade A, a complete whiteout. And this means that you've got cement permeating all the way into the bone with no radiolucent lines. As you move down, you can see in a Barrick D, you have a radiolucent line all the way around the stem, and you would think in many ways that this is loose. So how do cemented stems fail? Well, Gruen gave us his zones. So if you look at the AP of a cemented stem, you number them from the greatest trochanter going down the lateral side, 1 to 3. The tip is then 4, and then 5, 6, and 7 as you go up the medial side of the stem. On the lateral, you do the same. So anteriorly, it would be 8, and then you work your way all the way down to 11 at the tip, and then 14 up the posterior side. So how did they fail? Well, Gruen proposed that there was 4 methods of failure. Mode 1 was split into A and B. So A is pistoning. So pistoning is the stem moving. So you could have the stem moving within the cement mantle. So the cement mantle was well fixed, but the stem itself was loose and would move up and down. Or you could have the cement bonded well to the stem, and actually all of the cement moves up and down within the femoral canal, and that was a type B failure. Type 2 was a medial pivot, and if you think about that, you would therefore get loosening in zones 7 and zones 3 particularly, as it was to rotate around that medial pivot. If you had good fixation at the calcar but not distally, you would get your loosening zones in 3, 4, and 5 predominantly. And Barrett grade 4, Gruen failure 4 was when you had a good distal cement mantle and the stem itself flagpoled, and then you would get a stem fracture typically, and you'd get loosening in zones 1 and 7 and maybe 2 and 6. But distally it was well fixed, and it would be bending constantly until it would the stem itself would fail. So you may see some of these x-rays. So then if we move on to uncemented stems, so these do not use cement. They use an initial rigid fixation. So we broach the femur, and we either use a press fit technique, where we have the last broach is slightly smaller than the actual stem, or a line-to-line technique. And most of these are line-to-line these days because that reduces your risk of fracture. So the initial fixation is you wedge that stem in and it fits nicely. The long term is actually biologic fixation. So the bone ingrows onto the porous coating of the stem, so because of the porous coating of the stem, and it has a rough surface, so you get ingrowth and on-growth. And then most stems nowadays have hydroxyapatite, which speeds up that biologic fixation by getting bidirectional closure of the gaps. So for bone ingrowth, you need your optimal pore size, which is 50 to 150 microns. Your porosity needs to be around 50%, and your gap distance has got to be less than 50 microns. And then you need to have a well-sized stem so that you minimize the micromotion, because if you get micromotion of that stem inside the canal, you're likely to get a fibrous coating, and therefore your stem will never be have that bony ingrowth and on-growth. And like I say, the HA coating causes bidirectional closures of gaps, so you reach biologic fixation quicker. Design types. So designs have changed again in this. So we used to have fit and fill stems. These were big stems. Their fixation was mainly distally. Patients would get problems with thigh pain until the bone remodeled. And actually, if you look at some of these older designs, you'll see that the proximal femur is actually expanded in its cortices proximally, one, to reach the modulus mismatch between the material of the metal, but also because it was so stiff, it would remodel. And when it remodeled, that thigh pain would go. Fracture was a common problem. And you'd also, because they were distally loaded stems, get a lot of proximal bone absorption because the metaphysis was not really loaded that well. Newer designs are metaphyseal loading. So you use impaction bone grafting. So as you are broaching that, you're pushing bone to the side to get a nice bone mantle around. What you're doing is you're upsizing in the metaphyseal region with each stem so that you get good rotational stability. The distal end of these stems have very minimal increases in size. This reduces the fracture, and also you load your bone better proximally. A quick look at cups. So cemented cups is what Charlie brought us. They work well. However, if they're going to fail, they fail because of the shear stresses across the hemisphere. They're very good for the elderly population. So if you have someone over the age of 75 and you put a fully cemented stem in, it's supposed to outlive the patient, and that's what the Exeter series supports. The failures in the 40-year Exeter series were mainly because of the cup failing first, and they were then excluded from the universal series. If we look at the areas that we want to look for lysis, you look at Charnley-Lee zones, and there are 3 zones. So you put a dot at the center of the rotation of the hip, and then draw a line superiorly, and then 190 degrees, and then that divides you into zones 1, 2, and 3. Zone 1 is a difficult zone even when you first cement into this, because we always seem to see a slight line in this zone, even at day 1, and that's often because of the sclerotic nature of the bone and us not getting a good drill hole in there to get good permeation. But when you're reviewing these x-rays with cemented cups, you want to look in all of these zones and see if you're seeing areas of lysis behind. Nowadays, we are more likely to use an uncemented cup, and like I was saying, in the UK, you're starting to see this hybrid hip, so a cemented stem with an uncemented cup. And this is because we see that these fail less commonly than a cemented cup would. The hemispherical, you generally use a press fit technique, so you underream by one and then you wedge this in, so you get your initial stability by a press fit, and then you get your biologic fixation. They're usually very porous, they have HA coating, so again you get your biologic fixation more quickly. And if you need to, you have the ability to place screws. So if you're placing screws, you must feel that something wasn't quite right with that cup when you first knocked it in, and those screws will realistically be your safety net for the first 6 to 12 weeks whilst this cup is getting that biologic fixation. Problems with screws is it increases the effective area of the joint. So if there is areas of lysis, you've now got a larger surface area. They are preferred in younger patients, like I was saying, because they're less likely to fail. And the other advantage of these cups, and I think why they're getting more popularity, is you can choose different liners for the same cup. So commonly poly, you can do a ceramic or you can do an MDM, so that's a dual mobility where you have a metal liner with a plastic and then metal or ceramic head, which gives you increased stability. So when we look at bearing surface, there are two broad categories: hard on soft and hard on hard. So hard on soft is your metal on poly or your ceramic on poly, and these work with boundary lubrication. So the hard head is rubbing against the soft polyethylene, where with hard on hard, which is your ceramic on ceramic, your metal on metals, and I would recommend you don't say that you would do a metal on metal, and I certainly would counsel you ever against saying metal on ceramic, because they were the worst combinations. And these use a mixed lubrication pattern. So initially at startup, when you've been sat at rest, the two surfaces are close together, so you get a boundary lubrication. But then as you get this hip moving, more fluid is brought in, and you're supposed to get almost a fluid film lubrication. So that's why wear is technically going to be a lot less in a hard on hard. However, for me, the exam answer is going to be a hard on soft. They've got the longest follow-up. They have so metal on poly is the longest follow-up, and it works incredibly well. And with the new highly cross-linked polyethylenes, the wear rates are even better than they used to be. You've got to understand as well, with the ceramic on poly, which is becoming increasingly popular, they are said to have a lower infection rate. If you look at some of the registry data, and they propose that is because of the wettability of the surface, so that bacteria is less likely to adhere to the surface of a ceramic head than a metal head. It also has less scratch properties and so on and so forth, so it should have a lower surface area. The other thing to think about is head size. So when we used very big heads, you had a thin poly, and this led to catastrophic failure, so you don't want a big head. Likewise, if you have a small head, you get linear wear, so that they wear out in a different way, but they also have a smaller jump distance, so they may dislocate more easily. So the ideal head size we've come to is a 28 or 32, and we compromise wear with stability. If you go to a 36 mil head, you increase your risk of trunnionisis, which is where you get metal ions released from the trunnion, and you can get that same pseudo-tumor type pattern that you would get with a metal on metal, and it's because of the forces in rotation, so that torque force around the head on the trunnion, we think, that is causing increased iron wear at this modular junction. If we look then at metal on metal, there is only one indication in the UK that the MRHA will let us use it in, and that's young men with good bone stock. I think this was the only ever indication, but the problem with metal on metals is we started to use them in everyone with any condition, and it particularly failed in those small women with small bone stock. What it does is it generates cobalt and chromium particles, and these are biologically active. So although they're small in size, you get a large volume of these, and because of their metabolically active, you can get pseudotumors. I was fortunate enough to work with Professor Alistair Hart down in Stanmore, and he was the sort of the research brain behind the parts per billion, which is 7 parts per billion. If your cobalt and chromium levels are higher than that, it's likely that this is going to start having a problem. And he set the MRHA guidelines. And whilst I was working with him, I have to say the revisions I did for metal on metal hips were some of the most complex, some of the biggest lesions that I had to debride, and then the reconstruction was complex, where we even had to use bespoke 3D printed implants in order to actually get our reconstruction. So metal on metal, I would not say in the exam. Ceramic on ceramic, though, if you are going to use a hard on hard, you want to use a 3rd generation alumina because they've got better properties and are less resistant to failure. They have low wear rates. You do have to put them on the inside of a metal shell, so that you can't just put a ceramic in. And the head size is dictated by the cup size. So the size of your cup that you put in will allow you to put a bigger and bigger head. Issues you need to be aware of are squeak, which is a vibration that is felt by the patient. Sometimes that becomes audible so that they can hear it, but the majority of the time they feel it as a vibration in the hip and they don't like it. Often it resolves after 12 months, but for those patients that it doesn't, it can become a problem that means that they want their hip revising. Ceramic fracture, though, which is rare, is a complex revision problem, because for me, a ceramic is an end bearing because it's the hardest thing you have. So if you revise it to anything other than a ceramic on ceramic, you're likely to have that fail earlier. There is some data to support that a ceramic on poly is lasting as well as another ceramic on ceramic would, but again, it's an unclear area, and if you're getting asked questions like this in your exam, I think you're doing incredibly well. So yeah, I'll move on. So what are the complications of hip replacement? So about 1 to 2% of hips dislocate, and for me, dislocation is because of poor component positioning and inadequate reconstruction of soft tissues. So leg length, offset, and center of rotation weren't right. If you get these things right, it's unlikely that a hip will dislocate. Aseptic loosening is a long-term problem, and that's one of the reasons we revise hips. Infection, around 2 to 4% of all implants that go in will have an infection, and that can be a difficult problem. Periprosthetic fractures, this seems to be an increasing problem in the way in which these elderly patients are living longer, and then they fall with their implants in situ, and therefore as a trauma surgeon I'm seeing an increased number of these coming through my practice. Metal debris, again, that's the other common reason for revision in the UK, and a lot of it is because they've got metal ions that are raised, and also they're starting to get problems, so they're asking for these to be revised. So there's an increased revision rate in our metal on metal hip population. So I think that was pretty much a whistle-stop tour through primary joint arthroplasty, and I would say that you're very likely to get asked about this. If you're asked about revision surgery, you're doing incredibly well. As for most candidates for the exam, they're unlikely to be asked much about revisions, apart from maybe position and approach, which again, posterior approach, and then the reason why. And it's all about planning. So in anything you do, if it's primary or revision arthroplasty, it's all about the planning. So you'd want to be talking about that. So for me, a model answer, you want to be thinking about the age of the patient. So if they say the patient is over 75, I would do a hybrid hip replacement. If they say they're younger than that, I would do a uncemented hip replacement. I would do a hard on soft, so ceramic on poly bearing in either of those. And these are all non-controversial. So this is a model answer that you may want to give. But again, you need to phrase it in your words and be able to back things up. And I think if you follow these sorts of bits of advice, then hopefully you then don't poke the bear. I wish you all well with this, and if you have any questions, I'm very happy to try and answer them for you now. Thank you.
So thank you very much, Tom. I say, keep out of the radar zone. You're poking the bear. Mine is for don't fly in the zone of the exam. That's a very thorough presentation. Everybody's allowed to ask questions. So I've muted everybody because there were families shouting in the background. Now is the time of the answers to ask questions.
Well, I'll try and come on to the normal screen now.
Good. Question time, guys. You need to tell me who you are and what is your question, please. So you stunned them. Everybody's gone quiet, isn't it?
Well, yeah, I've given them all the answers, you see.
So a couple of things. In Pakistan, people are fond of doing fusions or orthodesis. Is there a salvage joint replacement that you can do, or is there evidence to support that you can actually convert an orthodesis into a joint replacement?
You can convert an arthrodesis into a joint replacement, but again, it's all in the planning. So for me, you'd want to look at their muscles. So an MRI scan would be important to make sure that they had good muscles, because if they've got none or poor muscle function, then your reconstruction is going to be difficult. So if you are reconstructing though, I would, from an arthrodesis, I would use a dual mobility bearing, and then you could do whatever you wanted with the stem and the cup to make it fit really. But it's a difficult operation. It's one that we don't really do, and you've got to ask, if you've done an arthrodesis and they're pain-free, why would you want to try and take that down to get movement? You're likely to cause problems, and the commonest reason that an arthrodesis that you convert to a total hip has a complication is a dislocation. So I would, if they've got a pain-free arthrodesis that they're able to walk around on, I would tell them that that's probably as good as it's going to get. And in improving their range of motion, you may increase their risk of complications, particularly dislocation.
So the other thing is, guys, remember, the indication for England is different, or UK that is in Pakistan. So I was in a meeting and somebody said, what is the indication of joint arthroplasty? What is the correct age, ideal age? So the ideal age, you find the life expectancy. And because we think that everything gets revised in 10 years, so you minus it from 10. So if your life expectancy is 80, then 70 is probably the ideal age to do a joint replacement. We'd like to defer them. I mean, in rheumatoids and everything else is a different story, but that's ideal. So the ideal age or the life expectancy in Pakistan is 60. So the ideal age for them to have a joint replacement would probably be 50, because at 10 years you need to revise them or got near revisions. But that's the correct answer is you find out what the life expectancy is and take 10 years out of it, and that's what the correct age for doing an arthroplasty is. Okay, boys, don't embarrass me, ask questions. You're all quiet.
I've got a question.
Okay, one at a time. Salman, you first.
Assalamualaikum, sir. My question is regarding sir arthrodesis. I apologize in beforehand. Sir, it mentioned that we preserve the abductor mechanism in arthrodesis. how is it possible to preserve the abductor mechanism? I don't understand this.
What Tom said was to make sure that when you are revising an orthodesis into a joint replacement, that the abductor mechanism is present.
Yes, I would do an MRI scan. So if I was to go from an arthrodesis to a joint replacement, I would do an MRI scan, and if they've got good muscles, then you can consider it. But like I say, I personally would counsel anyone against changing that if they've got a pain-free arthrodesis hip that they can walk on. I can promise you, you're going to get potentially more complications of a dislocating joint replacement if you change anything.
So for exam answer, I would say that I would prefer not to revise an orthodesis into a hip replacement. If there was an opportunity such as failure of union, there was non-union, there was pain and all that kind of stuff, then I would send the patient and refer the patient to an expert who is an expert on revisions of orthodesis. I would not volunteer the exam answer that I would do it myself. You will say that's a difficult problem. I have not seen many, or if you have seen, tell them this is what I've seen, but I will only revise a orthodesis to a hip replacement if there is non-union and there is pain and there's symptoms, because as Tom said, most of them will, with an orthodesis, do really well, and you don't want to do anything to tempt fate.
Thank you.
Yeah, I'd like to ask a question.
Okay, so I said always, rules is say your name and then your question, yeah?
My name is Kazim and I'm from Indus Hospital, Karachi. I didn't understand what you mean by end bearing when you told us about ceramic on ceramic. I would like a bit of clearing, please. Thank you.
Okay, so what I mean by end bearing is there's very little options to revise it to any other bearing type. So if you had a ceramic on poly and you were revising that, you could revise it to another ceramic on poly, metal on poly, or ceramic on ceramic. However, if you had a fracture of ceramic, you'll never get rid of all of the shards of ceramic that when you do your debridement, and therefore there's going to be a number of particles that stay around. The theoretical risk, if you put a collar in, is that particulate matter can then cause the poly to wear out at a faster rate. So therefore, if you put your primary joint replacement in someone with a ceramic on ceramic, you should revise them to a ceramic on ceramic. So therefore, it's an end bearing. There's no other option to revise them to anything else. I personally don't do any ceramic on ceramics. I would always do now a ceramic on polyethylene, even in the very young, because I understand the way in which polyethylene fails. I understand what it does to the bone. I understand that if there was a problem, that I can revise it to anything that I would like to revise it to in the future. So it gives me more options as a revision surgeon if I'm operating on the young.
Thank you, sir. Thank you.
Assalamu alaikum. I have a question, Dr. Shahbaz here.
Yeah, go on.
Dr. Tom, what's your opinion on dual mobility cuffs in primary total hip replacement? Because there is sudden uprise of usage of dual mobility cuffs in young patients especially, and it is claimed that they have got decreased long-term wear. So what do you say on this?
So the current biggest users that I'm aware of are the Europeans for dual mobility cuffs. They are very good for stability, but we haven't got any good long-term data, as in the primary total joint setting as a bearing. So the best, or the ones that we have the most data for, are metal on poly and ceramic on poly, and then ceramic on ceramic. So the dual mobility bearings may be the bearing of the future, but at the moment we don't have a good series that say that this is going to last 20, 30, 40 years without any problem. I think they're very good. I use them in every revision I do because they do give you more stability. And, you know, I justify using them in that setting. But at the moment, is letting us know exactly what the outcome is for these.
So we are losing you, but Tom.
Avoid saying them as a bearing of choice in your exam. I would go for the tried and tested metal on poly or ceramic on poly.
So the exam answer is you would not talk about a bearing or whatever implant in the exam. But in the revision setting, when you're talking to colleagues, you can discuss it. But in the exam, like Tom said, keep it simple, sir. I would say sir rather than the other word anyway. But keep it simple. Fly under the radar or don't poke the bear. Tell them straightforward that you will do a hard-on soft hip replacement, such as a metal on poly or ceramic on poly. You will tell them that you will try to do a hybrid in the elderly, and the young one you can do on cemented complete. Not make it controversial. Just to add on, Tom, Mr. Sadiq is a big name in Pakistan, and he has told everybody, and everybody believes this, that when you put the screw in to the cup to bring it to the socket, it uses the AO principle of compression, so the bones compressed into the socket on the metal level. They have good integration and they heal well. So unfortunately, examiners will be expecting that answer. So just please, guys, add on to this that if you are screwing it, it is the AO principle.
Yeah. It all depends on your technique. So if you do a line-to-line technique with your uncemented cup, then you do need screws. If you do a press fit technique and you get a good press fit, you shouldn't need screws.
Yes, guys, you must remember this. What's a press fit and what's a line-to-line, okay? And the other thing you must remember is everybody gets asked Charnley's low-friction arthroplasty, although a lot of people are not using it. But for the exam, you must remember the low-friction arthroplasty, and it has one of the best results of any hip, and it's also one of the best results in the young adult hip. So if you get snookered, caught, or get into a corner, always talk about Charnley's low-friction arthroplasty. Okay, more questions, guys? Shehbaz, you wanted to ask a question, is it?
I did, basically. One more thing, because I'm done with my FCPS, so I'll ask a bit complex things. So in press fit situation, basically you need a rim fit. So that is the thing where you need a grip. So why that is one of the reasons you don't need screws in press fit. If there is some condition like patient had some fracture of posterior wall or something, then do you think the press fit cups do well?
So it depends. If you get good stability, so if you get a fracture when you're putting your cup in with a press fit, you need to test whether or not that cup is still stable. If it moves or anything, then it's unstable. Okay, so you would need to use screws to augment your initial fixation, because ultimately biologic fixation will happen at 6 to 12 weeks down the line, but you need to hold it in the position that it's in. So screws are a good idea at that stage. If you feel though that it's completely stable and you are being brave, then put screws. But for me, if you get any crack that you see, I would always add a screw, well, 2 screws. I think if you add 1 screw, you can still get that cup spinning, whereas 2 screws should prevent any rotational instability. So if you feel that you've cracked the acetabulum when you've done your press fit, then I'd always put 2 screws.
Again, all your examiners are trained by Mr. Sadiq. So Mr. Sadiq tells them to take a bone graft and reverse ream it. By reverse reaming it, he makes it enough for the cup to stand. But Mr. Sadiq always says whether you put a line-to-line fit or press fit, you should put screws in because of the AO principle. So it is not what evidence suggests, but it is what he has told all your bosses. So all your bosses know that, so you must know this to talk about if you have to. That's all I'm saying. I'm not saying it's evidence-based. All I'm saying is your bosses have been taught that by Mr. Sadiq for the last 20 years. You have to take bone graft, you have to reverse ream it, you have to put a cup into it, and you have to fix it. Now, dual mobility cup is something that Mr. Sadiq is now using, introduced into Pakistan. So you don't need to talk about it unless somebody asks you. It's the same thing that Tom said, don't poke the bear. If he asks you, then you're doing really well. If somebody's asking you that question, you've passed your exam. So don't volunteer that information unless somebody asks you.
Sir, this is Uzair from Gurki Hospital. I wanted to ask about the difference in rehab protocols in all the different settings, in uncemented, in hybrid, and then fully cemented?
So my rehab for all my patients is full weight bearing as pain allows. People may suggest if you have a fully cemented hip in, that you partially weight bear for the first 6 weeks, because that can help to reduce the micromotion of the stem, therefore reduce your fibrous union, etc., etc. I'm not a great believer in that, so I fully weight bear all of mine as pain allows, and I try and get everybody out of hospital as quickly as I can. So I do things slightly differently, but I suppose if you're doing this, so with your cemented, you fully weight bear them. With your hybrids, you fully weight bear them. With your uncemented, I still would fully weight bear them, but you can argue that you'd partially weight bear for 6 weeks.
So this is a question for everybody else, not Tom, for everybody else. Okay, so what is partial weight bearing? So if you've now woken the bear and talked about partial weight bearing, you have to know what partial weight bearing is. Guys? Shahzeb, you want to say something, yeah?
Can you hear me?
Yeah.
So I think it is merely a 25% weight bearing.
30%.
With
one-third body weight. So
with
patient practice 1/3 body weighting, and that's what you should do. But I am of Tom's opinion. I will always weight bear fully within pain limits of whatever joints I've replaced. Like I said, I don't do anything below the belts anymore. But when I did, I used to replace them. But in the exam, the safe answer is you should weight bear the uncemented one straight away, and the cemented one you should wait for 6 weeks to stop subsidence and micromotion. And also, there is biologics which says that if you have an uncemented stem, it will have micromotion, it will break a bit. That will make a fibrous tissue, but that healing will, as a fracture, heal because it's bone going into that. It will become a big solid, attachment to it. So you're allowed to weight bear the uncemented one, but the cemented, for safe reason. Father's putting his hand up. You want to ask a question, Father?
Hi, Michelle. Tom, great presentation. Can you hear me?
Yes,
I can hear you.
I just had one question. Posterior approach is the only approach. But what if you have a hip fracture?
So if you had a intracapsular neck of femur fracture and you wanted to do a total hip replacement, I would do a posterior. If you were going to do a hemiarthroplasty, I would do an anterolateral approach. Why
that difference?
If you were to do a hemiarthroplasty through a posterior approach, theoretically, if you don't do it as theoretically, you increase your risk of dislocation. And we know with the anterolateral approach, dislocation is rare in hemiarthroplasty. For me, if you do a total hip replacement for trauma, they're more complex because they don't have the tightness of the capsule that comes with arthritis. They don't have soft tissues that are, like I say, basically contracted. So actually, there are more complex reconstruction, and you're more likely to increase offset and leg length in the trauma setting than you are in the arthritis setting. And also, your risk of dislocation is much higher in the trauma patients. It's around 5% as opposed to 1 to 2%. So all these things, come into play. But for me, if you're doing a total hip for trauma, it should be an arthroplasty surgeon who specialises in hips that should be doing it. It shouldn't just be a general trauma surgeon.
So I agree with that. That's why I don't do hip replacements when I'm on call, because I ask my colleagues to do it for me. But that paper's come from Sheffield, and Sheffield, the dislocation rate was higher in trauma, but then they subclassified and they find out that a lot more unspecified, unqualified arthroplasty surgeons were just trauma surgeons doing them. Therefore, they had a higher rate of dislocations. If you're qualified by arthroplasty surgeons doing hip replacements in trauma with a posterior approach, the dislocation rate matches the arthroplasty group, although you have to think that the capsule is a bit tighter in arthritis. But if they separated the proper arthroplasty surgeons and everybody else, and they find out that if the arthroplasty surgeon did it, their dislocation rate was not as high as 5 or 6%, which was quoted in the paper. Go on then, Fad.
Michelle,
yeah.
For a matter of debate, I know we're digressing a little bit, but you see some trauma centers have now allowed trauma surgeons to do dual mobility cup and the anterolateral approach. Does that, using the combination of those two, make total hip replacement for hip fractures more generalizable?
I don't know, because I have such wonderful colleagues that I don't do a hip replacement when I'm on call. But I don't know what the real answer is.
An approach is an approach, and if you can use an approach, it doesn't matter if you can put your components in the right orientation and you can restore center of rotation, leg length and offset, which are Charnley's principles, using a direct anterior, an anterolateral, a posterior approach. It doesn't matter, because it's about the reconstruction of the hip and the soft tissues. I think if you're talking about less experienced surgeons doing it, then yes, dual mobility is going to help with stability and reduce dislocation. But as long as they can use an approach and get the components in the right orientation, then they should get a relatively stable hip. Hip replacement has been done by many different approaches, and I do it the way I've always been taught, and likewise other people do it in a different way. But as long as they're comfortable with using their approach, it doesn't matter. An approach is an approach. And I've dabbled with direct anterior approach, and I think it's good, but it's difficult to get your head around with a big learning curve at the beginning. And so you really have to invest in doing it in a lot of patients in order to understand that approach and minimize your complications. So for me, do what you do well and continue doing it in that way. So I'll always do a posterior approach, but I know a lot of my colleagues at Walsall do a direct lateral approach, and in their hands, they find that very straightforward and they understand it. So I leave them to it.
Yeah. So, I mean, guys, exam questions only, don't go out of the question, but I will just call it, when I was training for my registrar rotation, I worked with Derek McQuinn, and he used to say there is only one approach, the posterior approach, everything else is the burglar's approach to the hip back. So, but that, if it's an exam question, let's do that, because this is only a basic forum. We don't want to scare the rest of the guys who are doing exams in a couple of weeks' time. So, any exam-related questions on the topic? If not, then we can call it a day, and thank Tom for it. Okay, Shahbaz, you want to ask a question? Shahzaib.
My question is, we were talking about press fit. For instance, we were doing a press fit and we cracked the below, or we just assume that we've cracked it. So what is the rehab thing? How do you do it? You just go for a complete full weight, or do you do a partial, or you just put them non-weight bearing?
So if you've done a press fit technique and you've not augmented with screws, okay, then you worry that your component might not be stable. So you would protect weight bear that patient. But if you identified on table that you'd cracked it, like I say, I'd put 2 screws in and then I would fully weight bear that patient.
So we have a colleague in Birmingham, and he called it the feathered, I don't know what, light touch or something like that for fractures, but that's too complicated. So basically put a couple of screws into it and make it stable. And then if you're still unhappy, then do a partial weight bear. You can never non-weight bear a hip. Can you non-weight bear a hip, guys?
No.
Not possible.
The only way to do it is in traction. The only way to do it is in traction. Okay, anyway. Asad, your question?
Sir, I have a question. If we are going for conversion of hemi to total hip arthroplasty, and hemi was done with the posterior approach, so should we go with the same posterior approach, or should we change the approach?
So posterior is best approach. You've just been told 100 times. And if the posterior was done, I would stick with the posterior approach. And even if not, I would do it in the same approach, because you have what is called traum tracking. If you have 2 skin incisions, there's a track of skin in between it, which has lost its blood supply. So why make 2 incisions? Just keep a simple incision, And in the exam, pick one option and stick with it. Tell them, look, I'm familiar with this option. This is what I'm going to do, yeah?
I can promise you in the exam, if you're being asked about revision surgery, you've done very well.
Exactly.
And the answer is always posterior approach. So
Yes.
if the hemi was done through an anterolateral approach, I would still revise through a posterior approach, because I can get a better acetabular exposure. If there was a problem with the acetabulum or the stem, I can do an extensile approach that can go into a Cocker-Langenbeck or all the way down to the knee. You can't do that easily with a anterolateral or direct lateral approach. So for me, in any revision, you say posterior approach, you don't poke the bear in this exam.
Okay, guys, everybody happy? No more questions? Okay, well, thank you, Tom. And I've got a video recording of this. So once we finish, I'll post in all the videos in the forum. And thanks, Tom, again for taking time to talk to us. Everybody is enjoying. I mean, I was told that the better guys get better audiences. So I've never got beyond 18 people. You've got 26 today. So you've beaten me by a mile, as you would call it. Like.
Well, you know, all I can say is this is probably a 99% chance question on your exam. You'll get asked something about hip arthroplasty, so hopefully some of what I've told you will come up in some form, and you can not poke the bear. That's all I can say.
Okay.
So thank you
very
for
much,
giving me this opportunity
Hopefully
to
we'll
talk.
see you soon. Now we'll ask you, Tom, to come again and do the infection part of it also, yeah, if that's okay with you in the future. Thank you.
Thank you, sir. Thank you.
Thank you.
Thank you, sir.